the one thing I remember is I remember telling grad students when I was teaching about a decade ago, and I said, if I'm still giving paper and pencil tests 10 years from now, you know, this field has failed us somewhere. And sure enough, here I am still giving paper and pencil tests.
What is up, fam? Welcome back to the channel. My name is Phil Sarpon. This is Phil's Guide to PsyD. This channel is dedicated to all things psychology, wellness, and graduate school. Today we have a very special guest with us, Dr. Peter Dotzek. He is a board certified neuropsychologist. Before we go into that interview, I did want to let you guys know that you now have an opportunity to support the channel by becoming a member. Being a member means is that basically you get the opportunity where if you have a number of different questions, I will respond quicker to those questions for those who are members. You also will have access to other different videos that we do where we interview different psychologists or neuropsychologists. So if you want different perks or access or exclusive videos for those live streams, definitely also consider becoming a member. All right, so let's go into Dr. Peter Dotzek's whole bio. Dr. Peter Dotzek is a board certified neuropsychologist in both pediatric and adult neuropsychology. He specializes in the assessment and treatment of children and adults with a vast array of neurological and neurodevelopmental disorders. His particular practice specializes in dementia, ADHD, sleep disorders, dyslexia, pervasive developmental disorders in children with complex medical conditions such as epilepsy, traumatic brain injury, genetic and toxic metabolic disorders. He also is a clinical associate professor of neurology, as well as he teaches courses in psychiatry to second-year medical students that are involved in autism or Asperger's syndrome and neurodevelopmental conditions. He is also the previous associate chair of clinical psychology and behavioral sciences at Illinois School of Professional Psychology. He has published a number of different neuropsychology assessment and sleep medicine research articles and publishings, and he also has done a lot of work in relation to autism, dementia, ADHD, and sleep disorders. He even has recent chapters on issues related to pediatric neuropsychology. So Dr. Peter Dotzek has years and years of experience, and I'm super excited to get into this interview with him. So with that, let's go ahead and jump right in. All right, Dr. Dotzek, how are you doing?
I'm living the dream, Phil. How are you?
I'm doing well, living the dream as well.
All right, great.
Thank you so much for just spending the time with us. I know that you are incredibly busy and that there's a lot on your plate as a neuropsychologist. So I think me and both the audience really just appreciate the time that you have for us.
Oh, sure. I'm happy to be a part of it, and it mixes up my day a little bit. So that's helpful to do some different things. But I'm happy to be with you.
There we go. Well, we'll jump right into it. I would love to know, first of all, what got you into neuropsychology? So why you made the decision to specifically choose neuropsychology. And for someone who perhaps doesn't know too much about neuropsychology, how would you describe neuropsychology to them?
Okay, that's a lot. I'll try to unpack that one. When I was going to undergraduate school, I started off in architecture. So it's not the natural transition. I have a mom who is a psychiatric nurse, and my father is a civil engineer. And I think I thought for a long time that I had a little bit more of an engineering brain. And that's what got me into architecture. And then the first couple months on campus, they gave you the list of all the additional materials that you had to buy to be part of the architectural courses. And I was like, well, I don't have any of the money to buy that stuff. So I couldn't do the classes. And the building was just down the street from the psych building. And I had a couple people from my dorm who were taking psych classes too. And so I kind of migrated my way away from architecture and into psychology. And at the University of Florida, they have the clinical program. They call it Down the Hill, and it's about down the hill in where Shands Hospital, which is the major hospital there, and that was where they did a lot of the drug studies and brain research, and I got really interested in the behavioralism in the animal labs. But part of the research was to do evaluations on cognitive screeners on a number of elderly patients in the community, and I love the interaction with people and the assessment process much more than I liked anything else about psychology. Mm-hmm. And when I graduated, I'm not sure I really understood what neuropsychology was like at that point in time. I just knew that I had sort of a mechanical brain, and I liked the detective work of the assessment process. I'm not sure how good I am at therapy. I never have been. I mean, I've certainly taken all the classes, but when I took a year off between undergraduate and graduate school, I worked at one of the hospitals in the town that I'm from as kind of the mental health techs, because I think everybody's had that entry level job. And I did some observation at Fort Wayne Neurology, which is this large neurosurgery clinic in Indiana. And I got to shadow a couple of the neurologists, and they started talking about call. And I don't think I had realized that doctors really don't get time off. So if they're not working, they're on call and covering for other people. And I thought, wow, I can't do that. I need to have some downtime and be free. And they said, why don't you go see our neuropsychologist? And I said, what does he do? Just do therapy with people at the clinic? And they're like, no, he does assessment. And so I went and shadowed him for a couple of days. And I said, this is it. This is what I want to do. So when I was picking graduate schools, I just looked for those that had a developed neuropsychology program, and that was my primary area of focus throughout grad school and an internship and fellowship. So I think I knew early on. I've said to students over the years that I think a good neuropsychologist has three components. One of them is the clinical side, where you have to have people skills and empathy and be able to join with and understand mental health conditions, but also be able to give good news and bad news, and just be able to walk the road with someone on a journey where sometimes you're seeing them at the lowest point in their life. Mm-hmm. Another component is I think that most neuropsychologists are good detectives. They're good at asking questions and gathering information in such a way that it helps them to create the story of what the pathological condition that children or adults, if you work with adults, might be dealing with. Mm-hmm. And then part mechanic. Mm-hmm. And I think that's really where, even though you would think my mother as the psychiatric nurse would have been more of an influence, I think my father's engineering brain is kind of what I inherited. And so the brain is ultimately a system. And just like you would do if you went to the mechanic, you don't show up and say, something's wrong with my car. Can you figure it out? You say, it makes these noises when I do this at this speed and on this side, and they can, from the symptoms that you've given them, discern some differentials and then test accordingly. And I think in a lot of ways, that's the way the brain works too, is it's a system that is fairly knowable if you have the right set of symptoms. And so that was more of my journey into neuro. I may not be a good example of someone who meandered, at least once I got to graduate school, because I pretty much knew that was what I was going to do. You asked, what is neuropsychology? Yes. The definition is it's the study of brain behavior relationships. I'm not sure that tells you anything, but the way you would think about it is in I know that some of your audience might be people thinking of going to graduate school or in graduate school or maybe even out of graduate school. The way that I would describe it is there's three paths that have emerged in our field. And you have a neuroscience background, so you'll probably appreciate this, but there's cognitive psychology. So anybody who goes to graduate school will eventually take a course in cognitive and affective bases of behavior, and you learn what's called information processing theory. And in cognitive psychologists are good at saying, here's what a brain does. So you know that if someone gave you 2 + 6, the answer is 8. What you don't know is where in the brain that is occurring. And cognitive psychologists will study, hey, if you take in this information, here's what comes out. So common theories like Bataille's theory of working memory, where you have this central executive and this visual spatial sketch pad and phonological loop, and it describes how working memory operates. It doesn't tell you where, it just tells you what. But the field of cognitive psychology kind of emerged to help understand what the brain does. And it was a big reaction to behaviorism. Behaviorism was kind of like your brain's a black box and something happens and out comes behavior. But the cognitive psychologists were really interested in more information processing. At the same time, and maybe this is the world we're in now, is the evolution of neuroimaging. Neuroimaging doesn't tell you as much about the what, it tells you about the where. And so in neurosciences, you study, what the brain is and what it's doing. So you have these imaging models like CT and MRI who can show you if something's there that shouldn't be, if something's broken or damaged in real time. And then you have functional models which can tell you which part of the brain is consuming oxygen, blood, or resources, and therefore must be involved with the task. So that's a big upgrade in terms of where something's occurring in the brain. The problem with neuroscience is that although it's really, the images are sexy and people like to view it on in research and they make good video, if you can't do it in the tube, it's a little hard to study. So you can't study everything just because you have the ability to see what the brain is doing. And then this third camp is the psychologists who emerged, which is neuropsychology. And their goal was to study what the brain does and how it's damaged. So the classic holy grail of neuropsychology is what's called a double dissociation. And it's the idea that if you damage part A, you can still do behavior. If you damage part B, you can't do the behavior, but you can still do a different behavior. So like, again, for entry level stuff, it's the idea of like Broca's and Wernicke's area. You can have a person who can't speak but understands language, and another person who can't understand language but can speak, and you can figure out through injuries that they're different areas of the brain. So in an ideal world, if they work together, you'd have somebody building a theory in cognitive psychology of what the brain is doing, imaging people who could tell you where approximately that's occurring, and somebody who studies the kinds of injuries that might impact that and what the deficits will be. So that's the neuropsychologist, that's what they contribute within that field of brain study.
Gotcha. Okay. Wow. That was a great description of that. I'm curious to know, like, for you, the day-to-day life of a neuropsychologist. So what specifically, I guess, what conditions are you seeing on a day-to-day basis? What population are you working with? How does that actually go into a practical sense for your life?
Yeah, I mean, obviously, I'll caveat it by saying that I'm primarily pediatric and would only see kids if the world would let me. But there are others. In the last practice survey, I think this has held true for decades. About 60% of neuropsychologists are just adult. That's how they identify. That's what they do. And most adult neuropsychologists day to day will have to follow the pathologies that occur in adults. So if you're between the ages of, say, 30 and 60, the most common things that you'll see are head injuries, mostly motor vehicle accidents or falls, stroke, and multiple sclerosis or things like that. Things that occur at that age range. If you do geriatrics, then dementing illnesses will be your bread and butter: stroke, Alzheimer's, frontal temporal dementia, things like that. Deliriums, medical conditions for people who can't take care of themselves, when you're older, often result in cognitive difficulties that someone has to suss out. And then about 15% of us do, mostly kids, and the rest are what they call lifespan. Ideally, they work with all age groups. I would say in the practice studies, you see a decline in lifespan, a steady adult, and a slight increase in peds. So that's kind of been the trend. So I'm in a right now in an outpatient group practice. So and what is true of all pediatric neuropsychologists is you see conditions that occur in childhood. On the medical side, that's usually going to be some sort of complications of birth prematurity or injury, epilepsy, head injuries on the mild side. In kids, 90% of head injuries are mild. So, but they go to school, so they have demands on their cognitive functioning every day, all the time. So head injuries more on the mild side, and then a mixed bag of genetic disorders, things like that. On the neurodevelopmental side, ADHD, learning disabilities, autism, that's the highest occurring conditions in childhood. That's what you'll see most often. And it's somewhere in the 50-50 split, depending on the time of year. We see a lot less learning disabilities and ADHD in the summer because the kids aren't in school, but a lot more head injuries and other medical stuff because they're often pretty active. And it'll ebb and flow throughout the course of a year. But day to day in my practice, we're doing primarily assessments on one of those conditions. So I'll spend an hour with families doing intakes and finding out what they're here for, what's going on, what led them here, gathering the background, reviewing medical records, and then performing tests that would be germane to whatever brings them in. So if it's learning disabilities, IQ, academics, tests of phonological processing would be common. And then if it's autism, measures of social perception and repetitive behaviors and pragmatic language would be what you do. But there are tests. I think in the last count, we said that there was something in the neighborhood of 170 standalone or batteries of tests that can assess functioning in childhood. So it's a lot to know.
Wow.
You don't use them all the time, and there are variations on a theme. So if you know one academic test, you can probably learn one of the other ones pretty quickly, and after a while get familiar with its strengths and weaknesses. But we do the evaluation and then sit down with the families and walk them through what we found. And every parent wants to know two things: what is it, and what do we do about it? I think maybe one thing that might be more unique to my practice is we are also on staff at Northwest Community Hospital. So in the hospital, you go where they tell you. So a lot of times it's older people who are coming in who are confused or impaired, and they were found at their home and brought there by the EMS, but can't really give you a lot of details of what happened. And you try to go through the medical chart and the current symptoms and figure out what's likely to have got them there. You try to call family members where you can. There's been times where we've just taken their phone and called the last number they called and try to find somebody who can give us some information about what's going on. So again, you're always to the detective piece, you're always solving some mysteries, but you're usually trying to help the hospital identify competency, amongst other things. Are they capable of making their own decisions right now? Because procedures need to be run, and if they can't do it, someone else needs to. So it's a lot of acute work, at least for me. That's not true for all neuropsychologists, but
Gotcha. Okay.
yeah.
Very cool. I think one of the things that when I was looking at psychology schools, I had heard about neuropsychology, but I wasn't exactly sure what it was specifically until I got into grad school. And
Yeah.
then I'm in a neuropsychology practicum side now, so I'm learning a lot of the different even subspecialties even within neuropsychology. So I know you
Right.
talked about how the field has grown and there's been this expansion of different ways to assess and test people. Where do you see the field heading 10, 15 years from now in
Wow.
terms of intervention, perhaps drug interventions or different assessments that people could even create to further help people figure out what's going on?
Yeah. I think this is the part where, when you record it and we put it in that time capsule for 15, 20 years from now, you'll see how wrong our predictions are. I think there's some things that make logical sense, and I don't know how many years in the future they are. But the one thing I remember is I remember telling grad students when I was teaching about a decade ago, and I said, if I'm still giving paper and pencil tests 10 years from now, this field has failed us somewhere. And sure enough, here I am still giving paper and pencil tests. So, I'm less interested in how you make an IQ test able to be administered on a laptop. I mean, to me, that's just an evolving of technology, not of the field, right? But I am interested in how wearable technology, may influence how we gather data, right? From anything from like how kids are focusing in a classroom to, how much anxiety they really experience, and how virtual reality platforms or augmented reality, right? How you might use that for therapy for panic, or also assessments for ADHD. They have a few of the virtual platforms that mimic a classroom, and you can see how well a child can attend to a lecture. Again, I mean, I think that it's limiting to what you can do within the tube right now. But I could see a time where you could measure in real time regional brain activity to the point where you could use that diagnostically to say, okay, is someone's frontal lobe not coming on as much as we might think, and could that be indicative of ADHD? They do some of that with what are called quantitative EEGs, where they measure the driving response, right? Which should happen in your frontal lobe if you're doing something that demands the frontal lobe, solving math problems in your head or something like that. You would expect that the frontal lobe would be more actively engaged, and perhaps someone who either at rest or during a driving activity has a less robust response, that might be indicative of some disorder. And you're seeing more and more the QEEGs. Right now, I would say they're a way to be wrong more often. They're not quite as accurate as the way that you would do it in neuropsychology in terms of diagnostic accuracy, but that's to be expected with new technology. And I don't think that means it can't get to a point where it becomes part of the battery. So I see neuroimaging playing more and more of a role in the diagnostic part, and I see wearable technology and AR and stuff like that being more involved in therapeutic interventions potentially as well.
Yeah, that's super cool. I think one of the things I love about neuropsychology is that it does seem to kind of bridge elements of the medical profession, and having the opportunity to work in hospitals alongside doctors or neurologists, and kind of perhaps bridging the gap between what technology and some of the assessments. And so I'm excited to see what the field could hold, definitely in the future.
And I think that's the right attitude too. I think I've met so many colleagues over the years who have been apprehensive or nervous that somehow technology will replace neuropsychologists. And, what I always say to them is the first time they have something new out to assess ADHD that works, I'll just own it. Right. I mean, I'm not going to run away from it. I'll just embrace it into my practice. And so I've never found there to be a worry about the human element, because there's one thing to make a diagnosis and to be somewhat accurate. It's a whole nother thing to help the family figure out how to deal with it from there. Right. So I do think, and to your other point about pharmacology, I think they're moving more and more now towards tailored pharmacological interventions, right? Like they're saying it's not depression, but your depression. It's not, necessarily about, if you ask me what ADHD medication works best, I'd say you asked the wrong question. They all work about the same, but they have different cost benefits in terms of how they're administered, how they're tolerated, and how long they last. But I can certainly see continued advancement in drug treatment. Now, again, at the risk of being in this time capsule a decade from now, I was also telling students, no, that's not true. I'll go even back further. I was in graduate school in the 1990s, just to date myself, and they told me we've been studying Alzheimer's disease and we're 5 years away probably from a good treatment or a cure. And then when I was out practicing, we'd start learning more during fellowship, and they'd say we're about 5 years away. And I went to a conference yesterday, or not yesterday, like 2 weeks ago, about the new vaccine to put in a derivative of a treatment for I think it's Merck's, right? No, I'm sorry, I might butcher that. I think it's Merck's new drug, but they've developed something that can theoretically can teach your body that the beta amyloid that you accumulate that builds the plaques and tangles of Alzheimer's disease, they could potentially flush it and lower it. And they said, guess what? 5 years away from a cure for Alzheimer's. So I at the risk of sounding ridiculous, they do tend to be making more and more advances towards different pathological conditions. And the process seems to be that you find a way to arrest the condition. And you'll see that like in multiple sclerosis, where they can do some things now to keep you fairly functional. And maybe Parkinson's might be quicker than Alzheimer's, but at some point they may be able to arrest the process. And then from there, you start seeing things that can ameliorate it. But I'm really excited not only about how we understand the human genome. And I don't know if this was common to where you are, but they finally mapped the rest of it, right? They just finally mapped the rest of DNA. So now they found other things within that could lead to treatment. So it's always a stepping stone. You're always building on previous scientific discoveries. And I think you'll see changes for sure in pharmacological interventions as well.
So I'm interested, I know you do not just the clinical work, but you also do research and teaching as well. Is there one thing that you love the most about the field and the profession? And also, I think I'd be interested to know if there's one thing that you don't like about being
just
a neuropsychologist. Just one. Just one.
Well, I think that for me, that variety is what I enjoy the most. So there's teaching and there's training, and there's nothing more satisfying to me than the training of students. I think, just naturally when you reach certain milestones professionally in your career, you start thinking back and going, what's next for me? And I have found, as I've gotten older, that I don't have this drive to accomplish, to publish the way that I did. Now my drive is to either build more in terms of creativity and how I practice, and to just give back. My job now, I see, is to train the next generation and give them the tools that were given to me. And I get a lot of satisfaction out of that. Teaching, I teach basically courses that I would know, right? So I teach courses in forensic neuropsychology, pediatric neuropsychology, and neuroanatomy pathology. So I don't have to teach any students who don't want to be there. And because you're in grad school, a significant percentage of your classes, you're taking them because they made you. Like, it's not what you want to do. It's better the further you go. For those of you at home considering graduate school, it does get better, but there are still things you don't want to do. So I'm fortunate in that I don't have to teach any of the core stuff. So I'm just teaching the stuff that I know well. Research is, I am a PsyD, so I don't think I'm one that you would normally think of as being as heavy into research, but I'll tell you that all of my research is applied. So how assessment instrument work, how interventions work, long-term outcomes of things. I'm not as interested in the epistemology of the field. I'm more interested in the application.
Gotcha. Okay. Very cool. Very cool.
But variety. Okay. I didn't answer the other part. You said, what do I like? I like variety and flexibility. So you're always moving and you're never bored. I have learned to dictate. I was very fortunate when I first started practicing in a neurology neurosurgery practice. Everybody dictated. Nobody wrote anything. Nobody typed anything. And I got pretty good at that and pretty fast at that. So most neuropsychologists would tell you that writing reports is the thing they hate the most. And I don't love it. But you're telling a story. And so if I'm allowed to be a little creative in the way that I write, I can tell the family and the people involved the story of the kid. I feel like, you're always dealing with extraneous variables. So I'm not in love with requesting authorizations for insurance and dealing with the bureaucracies who are the payers. But I feel very strongly that I pay health premiums for my insurance. You pay health premiums for your insurance. To not be able to use your insurance because somebody wants a few more bucks just does not seem to be ethical is the wrong word. It's completely ethical to be a for practice and fee for service, but it doesn't seem to comport with my values. But it does create that other third party that you have to interface with. And then, you know, the other side of kids being the most valuable thing a parent has is that, you know, the,
Yeah.
the parents are often some of the causes of the problem, and they can be very challenging to deal with. And so it requires um, a level of patience all the time. You can't just say, well, I was nice to 25 of the 26 people this week. You got to do it for all of them. And I remember, I don't know for whom the saying is attributed for, but there is a saying that every person is fighting some internal battle that you know nothing about. And I think of that in when I'm talking with people and when I'm interfacing with them, that just because they're mad at me or frustrated or irritated, one, it doesn't mean that I did anything. But two, I have a curative opportunity right now if I can just get myself in the right frame of mind. But it is, I mean, it is challenging. If the kids would stop bringing the parents, that would be great. I don't
Just
see it
work,
happening, but that would be great.
just work with the kids. Yeah, leave the parents
Yes,
at
yes,
home.
that would
Yeah.
be my preference. But
That's awesome. Well, I know for our audience, there's definitely some people who are just trying to figure out how to become a neuropsychologist. And
yeah,
I know I've gotten questions from people who are in high school who are trying to navigate, okay, what to major in, how to go about college in terms of getting the experience. And then I think even in graduate school, like you can get into clinical psychology programs, but there's still a lot of work to do in terms of actually finally becoming a neuropsychologist, getting the neuropsychology internship, getting the experience.
yeah.
Any words of advice for people who are just trying to make those steps to actually become a neuropsychologist?
Sure. I mean, I don't know that I am the premier expert on graduate training in neuropsychology, but I guess I would say this. Um, you want to try to, I don't know if you're a Wizard of Oz fan, but they always told Dorothy, stay on the yellow brick road. And I think with students, I tell people, I want you to stay on the yellow brick road as long as you can, but you may not always be able to. So somewhere along the road, there's less than 10% of psychologists go into neuro. So it's not a large specialty, which means there's less opportunities for training. Um, Having said that, um, you don't have to be sure right away. I would say that for your people looking down the field, call people that you know who work in the field. Like I can't think of a year that's gone by where someone hasn't called and said, I'm in high school, I want to shadow for a week. And you'd be surprised how many people would either be willing to talk with you about it, or like we're doing right here, or let you come in and shadow. And so I think that that's a great way of getting a sense of it. Um, I think that undergraduate degrees in anything liberal arts can be useful. The problem with psychology is that they want you to take the core classes. There's 5 core classes that are required to go to graduate school, so you got to work those in. But any APA accredited graduate school has the same 5, so it's usually like abnormal tests and measures, statistics. There's a few of them that are on there, and you want to make sure you get those. But I've also been impressed by how many times in an undergraduate institution, if you just ask professors who are working in the graduate department, do you need help? Can I be a part of your research team? Can I volunteer for something? Can I help write something? Like I've never been told no on anything I was willing to volunteer for and not be paid for. So you can get more and more experience as an undergrad as well, and those things will help you in grad school. I think that for your people who are thinking about going all the way, and that's really what we're talking about. Like in psychology, an undergraduate degree in psychology is an entry mental health profession job, or a great stepping stone to a career in marketing, HR, or something outside of our field. But for those who want to go on, they right now, and I think this has been historically true, you don't see colleges and graduate schools growing at the same rate as the population. So the admission rate for APA accredited programs is somewhere between 8 and 12%, depending on which school and who you talk to. So again, with the idea of following the yellow brick road, Graduate with as close to a 4.0 in college as you can. Graduate high school with as close to a 4.0. Find your way to waste time other places, but you can't clean up messes with grades. So you want to do as well as you can, and then prepare yourself with standardized tests. And in undergrads, I think having a poster presentation that you present somewhere, doing that first step towards research, and making yourself as competitive both with grades and GRE is the key. And then I don't know, you're in graduate school, so I don't know what your experience has been, but I remember lying. That's what I remember most about the interview process, was just how many times you had to say, I just want to be in Dr. So-and-so's lab, and I'm really passionate about this, because there are these two camps. And again, for your viewers, roughly half the people right now graduate with a PsyD or a doctorate in psychology, and the other half graduate with a doctorate in philosophy in psychology. And in the PhD programs, they're expecting academicians, researchers. They're less about the clinical and more about the science in the field. Whereas I think in PsyD programs, the expectation is you're going to practice for a living, just like a medical student's going to practice for a living. So it's a lot easier to go into a PsyD program and have real, honest, candid conversations in your interview if you want to practice for a living. And if you want to do research and see a few patients on the side, you're probably better off in a PhD program, because they're going to be more aligned with your interest. And going back to the previous point, which is spend a lot of time in graduate school doing stuff you don't want to do, make sure you're in the right programs. It's going to make it easier. That I will say, and we can link it to your show notes if you want, but for those people who are in graduate school who are saying, where do I go from here? There are surveys that come out every decade. And there was one out last year where they ask internship directors, residency directors, what are you looking for in neuropsychology when you want a student to train? And there's been a nice shift, I think. I mean, it used to be that they overwhelmingly preferred PhD students. And what you see in the trends from the last few surveys is that now it's a PhD is still great, but it went from, I think, 15%, 15% of internships said we want PsyD student. We'll take a PsyD student. We want them. It's preferred, to 60. So you do, and you see that trend in board certification and stuff too, where more and more PsyDs have become an accepted part of the field. And so I don't know that there's quite that bias that there had been perhaps when I was in school, but they always say, they want you to have a lot of training and assessment. So you can't do enough in your practica. I think the last time I looked, the mean number of batteries for applicants was 20. And sorry, that's the minimum. Sorry, the minimum number was 20 and the mean was 30. And so they want a lot of experience in actually doing this so that they know you can hit the ground running when you walk in. We were taught when I was in school that you didn't understand an instrument until you'd given it 100 times. And that was because you had to see the instrument at different ages and with different conditions, and it just takes a while. So the more batteries you do, the more they know you're gonna be able to hit the ground running. I think in terms of placement, university medical centers, VAs, hospitals, they know you're going to see what they do every day. And if you're just working in a boutique private practice where you see ADHD and learning disabilities, that's fine if the internship you're applying to does ADHD and learning disabilities. But if you're expecting to transition into a highly competitive site where there's a lot of medical overlay, they need you to have seen it. So I think how you choose your placements can be helpful, and adding on that additional practica if you don't feel like your previous one covered it. I think the other thing that I would say is they like, most of the time what they'll tell you is they like publications. They're not the end all be all. They like you to be done with your dissertation. It's not the end all be all. but the more things that you can check off the list as you go through, the better. The one thing that is the hardest for graduate students is that they still list core coursework in neuropsychology in the top three, and it's always been in the top three. So any course your university offers in neuropsychology, particularly the neuroanatomy, neuropathology, do it. If your program doesn't offer it in the Midwest, Milwaukee has a brain cutting lab where they teach you basic brain slicing. They teach you basic neuroimaging, and you can add on to your curriculum. But that's what they want to see, is they want to see people who have had some organized training. So anything that you can take it, because that again helps pave the way. Make sure all of your rec letters are written by neuropsychologists, because they know you can handle it. Make sure that your dissertation is in the field, because what it demonstrates to people is that you have a commitment to adding to the body of research, the body of literature rather. So all of those things are within your control, even if your program, potentially doesn't have as much organized training in actual coursework in neuro. How is your practicum? Well, if you went to University Medical Center and you did a lot of neuropsychology and you exceed the number of batteries that most people get, they know you can do it. So all these things are just, build yourself up where you can with what you have.
I think that's great to hear, because I think sometimes for me, it was easy to think that it was very rigid in terms of like, you have to go to this specific school and then you do have to get this specific type of, like, I think what I've seen is that there is some room to kind of figure out, okay, I can choose this placement and with this population, and I can get this experience, and I can kind of build my resume even as I'm in graduate school to kind of help me to be the best applicant possible.
And I think also too, the competency in psychology is measured by licensure. That is why the APA always wants your courses to be broad in general. Fellowship is where you specialize for eventual board certification. But remember, this is important for your audience, there's only about 4 to 5% of psychologists are board certified in any specialty. It's higher in neuro because there's so few of us, right? So maybe it's more like 15%, maybe 20, but this isn't like medicine where 90% of people are board certified in their chosen field. So statistically, what are the odds you'll get board certified? You won't, right? If you're doing a research project and your significance is 0.5% or 0.05, right? Peak is 0.05. That's 5%. And the odds are you won't get board certified. So don't stay on the Yellowbrook Road extra 3 years in graduate school to get the best internship. Take an internship that meets your needs and doesn't limit you. The real factors are when people walk away from accrediting bodies. Like if you are going to a school that's not APA accredited, no one's reviewed your curriculum for competency. If you go to an APA accredited school and you're going to internship and you go to an internship that's not APA accredited, then no one's reviewed that. Oh, maybe they have the APEC, the matching service that you use. APEC has the same standards as APA, more or less, without the oversight. So, if it comes to that, and I have to consider taking a year off. I mean, if you look at, and maybe we can link a salary survey because they just had one come out. But if you think about every year you spend in graduate school, in neuro, you're talking about $100,000+ a year you didn't earn. And I don't know, what, I don't foresee that to be worth it to stay in school just to lose that kind of income loss, particularly when after 4 or 5 years of doing this, you'll know what you're doing. And then at that point in time, you can decide whether board certification is really relevant. I don't know if that's going to change, Phil. I really don't. I think ABEP has continually said, we want this field to be one where most people or everybody is board certified in their area. They have made no strides to doing that. And I don't mean that as criticism of ABEP. I'm just saying what right now, that number hasn't changed in the last 10 years. So I don't know what the future holds in that area.
Gotcha. Yeah, I've always heard those rumors like, go get board certified, go get board certified. But then you look in the field and you don't see that representation of people actually getting board certified. So Yeah,
it is,
it's interesting.
it is like publishing though, too. I think that if you've never published something, there's this fear, right? That it won't be accepted, that it won't be good enough. But I honestly, there's a lot of, if you have a good sample size and you have a clear referral question, and use a clear statistic, and you plan in advance, you'll get it published. And once you do it once, there's no mystery. And it's the same thing for board certification. I remember when I started in the practice I'm at now, and my colleague who works with child and adolescents, and I said, why don't you go to your ABEP and child? And he's like, what am I going to do with it? And I said, nothing. But but you're competent, you've been doing this a long time, and you talk about how you'd like to put those credentials out there and like to have the recognition of being board certified, and he coasted through it. And I just think he'd been doing this for a while, and it's minimum competency. That's what we're looking for in board certification. I think it's daunting to put your work out there, to have it reviewed by others and potentially criticized, but it's not insurmountable. And there's very few people, I think, who are licensed who probably can't get board certified. There's just a lot of people who don't want to put themselves out there or don't see any relative value.
Gotcha. So, Dr. Dotzek, I got one last question for you.
Okay.
This is a question that I ask to all my guests. One of the things that you hear a lot from me, like when I'm in graduate school, is this concept of self-care. And I hear the faculty members, talk about it. I hear the professors talk about it. But there does kind of seem to be a little bit of a disparity with how the profession is advocating for mental health, like with clients and patients, but also how they also take care of themselves. I would love to know a little bit of what you think about that, but also what you specifically do for self-care, whether for your physical or your mental or even your spiritual health.
Yeah, it is a great question, and you raise a fantastic point. B.F. Skinner said that the problem with psychologists is that they think that they're a psychologist first and a human second, and that is the source of all their problems. And so I think you see that, right? It's like the physician heal thyself. You think I'm here to help others, but if you got on an airplane and you were traveling with the child, they'd tell you when the masks come down, put yours on first, because if you go down, you can't get it on the kid. And so I think that you're right, that self-care is given more lip service until there's something to do, right? And then everybody's like, yeah, self-care once you're finished with finals. Why don't you self-care once you do all this other stuff and write this report? And I am pretty dogmatic about, or rigid about, my own sort of self-care. Like, I won't let a day go by where I don't think to myself, what have I done for myself? And what have I done for my family? Because they're the other people who get lost in graduate school, is your family. And so, I tend to have fallen into a routine of, I do the work that I'm here to do, and I love my job, and I love going to work every day. But when I get home, I have 2 kids, so it's family time, it's dinner time, it's homework time, it's carting people to sports and all that stuff. And then when it's done, that's when the kids want you. Like, when you're trying to put a kid to bed, you'll hear everything about their whole lives, or indefinitely. So you just let it happen organically. Don't try to force it at dinner time when they're more happy to talk at night. And as long as it's not going on to the extreme, that's a great time for me to connect with them. And then usually Dana, my wife, and I, that's right after they're done, it's kind of our time to connect with each other, whether it be reading or if we have shows we want to watch. I mean, the pandemic has tweaked all that stuff, but it used to be a date or dinner or walks. But more often than not, I find I'm the last one up. I'm just a restless guy. So then it's me time. And so sometimes that involves professional projects or writing that I want to do. A lot of times it involves exercise or running or things like that. But even if it's just meditation, just something, even 10 minutes, I try to make sure, get a kick out of this. When I was younger, I had called the day runners, and there was you made a little book and you carried it with paper. And my wife found it one time, and in there was like, a box for what did I do professionally today? What did I do for my body today, working out or what have you? What did I do to connect with friends today? What did I do creative today? And then what did I do for Dana? And I thought that when she found it, she would go, "Oh, it's so sweet." But what she took it as is, you had to put a box on there to know to do something nice for me each day. And I try to remind her, it's just, you got to make sure you get it done. And I don't want to, I know what's important, but I know people lose sight of it if they don't do it. So yeah, I think if you've got a final tomorrow that you need to study for, and it's going to take you 5 hours to do it, you probably can be efficient in 4.5 and keep 30 minutes for you. And I just want to make sure that it always gets done. And I think that's what's been the most helpful for me. I would say exercise, reading, and meditation are my go-to self-cares. But sometimes a cocktail on the porch and a cigar works too. So it just depends on my mood.
There you go. Got to balance it out a little bit, you know.
Yeah.
Have a little bit of everything.
Everything in moderation.
Yes. No, that's awesome. I actually work as a personal trainer part-time, and so I get those constant reminders for me, like as I'm training people physically, of like, oh wow, I should probably move as well. I should probably be active, and even the act of personal training is a movement for me to remind me of how I need to take care of myself. So I think I love how we have all these different reminders of how we can take care of whether our physical health or mental health. And even as we are super into what we do professionally, it's always nice to kind of escape and get that refreshment back to us. So
yeah,
that's awesome.
Maybe a question for you. Do you feel like it calls you? Like if you haven't exercised in some span of time, if you haven't done your routines, you find it, does it call you?
Yes, absolutely. I think that's a good word to put, call, because I feel like when I don't do it for a while, I get this sort of like nagging feeling of like, I really miss this and I need to go do it like now.
Yeah. Yeah.
So yeah.
Yeah, I think that's true. Spiritually, I think you if you get in the habits of meditating or praying or whatever it is that you do, you find that you miss it and you need it. And then when you're through and you come out of your meditation or your prayer or what have you, you feel a little extra. There's a little more juice in the tank to go do whatever the next thing is. And I always try to tell my kids, like, you can, they always say that worry is interest on a debt you may never pay. And what you want to do, you don't want to spend a lot of time like in your head worrying about or thinking about or stressing about. If you got something to do, just do it. If you've offended somebody and you know you should apologize, do it now. Right? If you've got homework, do it now. You could plenty of time for relaxation, but we spend so much of our lives. I wish they had an app for that, right? They have an app for screen time, how much time you're on a screen. I wish they had an app for how much time we spend worrying or stressed or procrastinating, because I bet I've got a whole nother life I could lead.
Right. Oh man, no, that's good. It's almost like I think even like you just maybe you plan for it, and then once you plan for it, it's like, okay, I'm not gonna stress about it anymore. I'm not gonna worry about it anymore.
Yeah,
I'm just gonna live my life. Yeah. No, that's awesome. Yeah. Well, Dr. Dotzik, thank you so much again for your time, your knowledge, your wisdom, your experience. I think the audience is really going to appreciate all the things that you've shared about neuropsychology, where the field is going, and just even what the day-to-day looks like. So I really just appreciate so much the time.
Yeah, thank you for having me, Phil. It's been a pleasure.
Yeah.